It's obviously an honor and a pleasure to be here. Wonderful institution, fantastic hospitality. Thank you very much. It's a beautiful city. And today we're going to talk a little bit about neurofibromatosis type 1. And really this is a condition that has made a remarkable transition in what we do therapeutically over the past 5 to 7 years because of the availability of new therapeutics for many of these things which otherwise were really not treatable. So as just as a way of introduction, it is a fairly common condition running in 1 in every 3,000 to 3,500, one of the more common neurogenetic or the most common neurogenetic disease. It occurs equally in all races and ethnic groups and occurs in both sexes equally. The diagnostic criteria for neurofibromatosis remain the same that it was laid out about 30 years ago in 1987. And there is some discussion of trying to add to these diagnostic criteria, but having 2 or more of these different manifestations is still been a very good working way of making a diagnosis of neurofibromatosis. The development of science, however, is age-dependent. 95% of children can be clinically diagnosed by 6 years of age. And there's overlap, and this is where we get into some issues. There's overlap with Legius syndrome, where you get the cafe au lait spots, but you do not develop the internal manifestations of NF, you do not develop the tumors. There's a real interesting overlap with mismatch repair or Lynch syndrome, because some patients with that condition have a couple of cafe au lait spots and develop tumors, especially intracranially, and people think, my God, this is NF, when it really is a mismatch repair. When you have a patient with about 2 or 3 cafe au lait spots and an intracranial tumor that's not a low-grade pilocytic astrocytoma, especially in a young child, I would think very hard about Lynch syndrome or the mismatch repair syndrome. And this raises the whole role of genetic testing for patients with NF1. Making the diagnosis based on the cafe au lait spots is not usually difficult, neither is seeing the axillary freckling. Remember, the neurofibromas are something that occurs later in childhood. And there are, within good laboratories, the ability to have diagnostic confirmation with molecular genetic testing. Now, the molecular genetic testing is not only for the truncated mutations, it's for a variety of different findings, and it's a multi-sequenced type of evaluation. And where we've seen people be mistaken is they depend on molecular genetic testing that is relatively incomplete. Also, molecular genetic testing will not pick up what is called mosaics, where the NF gene change occurs later in the cell division, whether you may have segmental or focal areas of abnormality that are NF-driven. But please remember that not all labs are the same. And the other thing is, with very few exceptions, there are very poor genotype-phenotype correlations. Whole genome loss, children do have more intellectual difficulties, maybe a greater likelihood of having tumors. There's a couple of point mutations that have greater mutagenic potential. But in general, even knowing the molecular specific gene defect does not absolutely tell you how this patient is going to do. Now, this is neurofibromatosis in a 3-year-old, and one of the other things that can be very helpful in diagnosis is these areas of abnormal signal scattered through the brain and the brain stem, seen best on the T2 weighted image and on the FLAIR image, that usually does not enhance. And I would say that about 90% of the patients we care for, if you look early in life, will have these kind of abnormalities. They are not, at this point, a diagnostic criteria for NF1, but in reality, many of us would be pushing towards having this, especially in children who have not that many cafe au lait spots early in life. They have a little bit of axillary or groin freckling that you can almost, these kind of changes are so classical for NF1, we tend to use them to help us make a diagnosis. Now, NF1 has many issues. And not all of them are gliomas or obviously malignant peripheral nerve sheath tumors. This occurs in the minority of patients, somewhere later in life, in anywhere between something like 8 and 13 or 15% of patients. But these things are very common, especially the learning and cognitive problems, and the gliomas and the neurofibromas, especially the plexiform neurofibromas, and there's many therapeutic issues. And one of the major things as we get into therapy, what is the benefit of the therapy, but what is also the acute and chronic effect of the therapy? Because unlike treating many things in neurooncology, most of these things are not life-threatening. And the question is, will the benefit of the drug or the therapy, will it really outweigh the potential toxicities of the drug, both lifelong, short-term, and long-term? And the other thing that we have to play as we decide who we're going to treat is the erratic natural history of the disease. The disease tends to spurt and stop. Most of the early growths, like the low-grade gliomas in the visual pathway and the plexiforms, really only grow in the first few years of life, and then they tend to stabilize. Some of the other growths, like the higher-grade gliomas, may occur later in life, and these are the kinds of things that you have to put into the equation. Now, the real change with NF has been the understanding that neurofibromin loss causes NF in this autosomal dominant disease, and that neurofibromin loss allows signaling through the RAS-MAP kinase pathway. And that has really dramatically changed how we manage these patients. One of the things that has always been a concern with the NF and the RAS-MAP kinase pathway is how often do these patients signal through other compensatory pathways. And if you really look hard at the data, it can be very difficult to prove how often patients with NF have abnormal signaling through the PI3 kinase. Now, there's work from David Gutman's laboratory in Washington University that suggests in his model that there is overexpression of mTOR and there is signaling down this pathway. In other people's hands, it's been very difficult to prove that NF is anything other than a single pathway disease. And this has significant connotations as regards therapy. Now, one of the frustrations of NF has been, even though we've known this pathway, we have tried multiple different targets over the past 10 to 15 years since we've known neurofibromin and known the pathway. And unfortunately, almost all of those targets, for a variety of different reasons, have not worked. Possibly there was a great deal of interest in using the farnesyltransferase inhibitors. They probably hit the wrong kind of farnesyltransferase. There's work with using the JAK-STAT derivatives, but they're relatively toxic and they don't get into brain well. We'll show you a little bit of data with the downstream effect of the mTOR inhibitors, predominantly sirolimus, which is rapamycin, and everolimus, which is RAD-01. We'll also show you a little bit of data with these higher inhibitors. Lovastatin, which is the cholesterol-lowering drug, does have a role in the RAS-MAP kinase pathway, and this has been a very interesting potential approach and seems to have worked for the cognitive issues in animal models, but have not worked in the human condition. So the frustration wasn't that we didn't have potential targets for NF. The frustration for NF1 was that we had these targets and they didn't work. And for a variety of different reasons, we couldn't make a dent in the disease. Then we walked into the whole issue with MEK inhibition because of the signaling down the RAS-MAP kinase pathway, and that was the game changer. That's the thing that has changed dramatically the way we treat these patients. Now, as far as the neurofibromas, and now we're going to break things into different ways of going about them. The neurofibromas are multiple different subtypes of growths. The ones that really are the ones for pediatrics that are a major problem are these very complex, what called plexiform neurofibromas, combined with Schwann cells and fibroblasts and a lot of other different cells. They grow at variable rates and variable locations. The superficial neurofibromas are really a problem in older adolescents and young adults, and they can be a significant problem, and there are potential ways that people are looking into treating them. But really the one that we work with predominantly in pediatrics are the plexiform neurofibromas. And these tumors can be diffuse, or they can be more circumscribed. There's interesting data coming out of the National Cancer Institute that we've been involved with Aaron Kim and our group, suggesting that the ones that tend to be more circumscribed, that are larger, about 5 centimeters or greater, are the ones that tend to have a higher likelihood of transforming into more of a malignant phenotype, the malignant peripheral nerve sheath tumor. Remember, only about 7 to 15% of these tumors will go into malignant peripheral nerve sheath tumors. But we are starting to feel more that it's these more circumscribed nodular lesions that are more likely to activate. These more diffuse lesions are remarkably difficult issues for patients, causing a multitude of different symptoms, both organ dysfunction, brachial plexus abnormalities, lumbar plexus abnormalities, and cosmetic issues. But the newer therapies have a real role in treating them, and interestingly, they are not the ones that tend to get into malignant peripheral nerve sheath tumors. Something that is being used around the country now in the United States, although sometimes it's very difficult to get insurance to approve it, is total body MRIs for NF1. With the right sequences, everything other than the brain can be well localized and seen. The problem with total body MRI is you may find lesions that are completely asymptomatic, and you have no idea what to do with those. And if you look statistically, anywhere between 40 to 60%, depending on the series, of patients with NF will have a plexiform neurofibroma somewhere. And if you know it, are you obligated to follow it? How often do you repeat the total MRI, the total body MRI? Another way to potentially follow these lesions is by using PET scans. But remember, PET scans have radiation associated with them. And we will do everything we can to stay away from radiation in NF patients, even at the point sometimes of being very careful to do scoliosis surveys, because we just don't want to turn these tumors into more aggressive ones. So the plexiforms have been a major issue. When they surround the spine, they can certainly cause neurologic deficits. The difficulty sometimes is localizing which one of this or which area in this large plexiform is actually symptomatic. Even if you have back pain, you have urinary problems, which one is the symptomatic area? And you can see that surgery has very little to offer these patients. So the plexiforms can cause serious morbidity. Pain is a big issue. Disfigurement can be a big issue. Life-threatening compression of the trachea, of the large vessels, the spinal cord, are all issues for some patients with plexiform neurofibromas. One of the major issues when we have tried to get industry to agree to try to help allow us to treat patients, they say that you can't even measure if your medication is working because they're so diffuse. Another large breakthrough has been the work by Dr. Wiedemann and Dr. Dombey at the National Cancer Institutes in the United States, getting a way to volumetrically analyze these tumors so we could follow them and see what their natural history is and see what therapy might be able to do. And if you take a look at the growth patterns of plexiform neurofibromas, they tend to be tumors that grow earlier in life much quicker. When you get older patients, there may be some slow growth, but it's more of a chronic problem with large mass of plexiform. Now, one of the earliest signs of potential efficacy was the case report that came out of the group in Indiana for the using Gleevec or amantadine in one very large head and neck plexiform neurofibroma. And this was published and had this remarkable response. Now, this was the first time we had tried a lot of different drugs for plexiforms, chemotherapies, thalidomide, which actually does have some benefit, of stability. Antihistamines have been tried. But this was the first time we saw dramatic shrinkage. The problem is that the mechanism of the shrinkage may not be a direct attack on the Schwann cells. It may be on the associated mast cells in this plexiform. So where Gleevec has had some degree of benefit has been predominantly in some of the large head and neck and pelvic tumors. But overall, the hit rate with Gleevec is probably in the 10% range. So the next studies that were done before the MEK inhibitor were with the data from Gutman and others about mTOR signaling down either the PI3 kinase or maybe secondarily through the MEK pathway, that mTOR might be a target. And there was quite a bit of studies done with rapamycin. And I'll show you a phase 2 study that has been completed with rapamycin, the sirolimus, and NF1-related plexiforms. Now, this only put patients who are greater than 3 years of age with inoperable tumors. There were 2 stratas, one that had evidence of tumor progression by MRI, a second who had no progression but were high risk, and a variety of different ineligibility criteria. What this showed was that sirolimus, this is the natural history of the disease, untreated, this is on the sirolimus, that it could delay the growth of a growing plexiform, but it could not really shrink it. So this was a minor victory that maybe in some patients you could delay the growth, but you really couldn't shrink it with the everolimus. At the same time, phenomenal information were coming out of laboratories, including Nancy Ratner's laboratory at Cincinnati Children's Hospital, that showed using a Pfizer MEK inhibitor in a laboratory model of NF, which was a very difficult animal model of NF that took months for the plexiform to grow, that she could show on a waterfall plot for the first time that over time you would see decrease in the size of the lesion. And in this waterfall plot, at a 5 milligrams per kilogram dose of the Pfizer drug, she could show almost 90% of patients having tumor shrink, of animals having tumor shrinkage. So this led to probably the most important study, the use of the AstraZeneca drug in patients with neurofibromatosis type 1 and plexiform neurofibromas that were published by Dombey et al. In the New England Journal of Medicine now about a year and a half ago, culminating on work, and we were a bit part of this with Ron Kim at our place, and this was very important. And what she showed was that with a variety of different doses of the AstraZeneca drug, that you could see in the majority, or almost in every patient, a decrease in the volume. And she took a standard cutoff of about 20 to 25% being an objective response, and using that cutoff because of these large volume tumors, and you could argue with what that means, that you could see that well over half of patients had what we would call objective responses, but almost every patient had some degree of shrinkage of the plexiform. And sometimes, and I'll show you one of our patients, this is for cosmetic reasons, but just take a look at what this has done over time, over 10 months of treatment with the MEK inhibitor, taking a look at how that is almost normalized cosmetically and decreased pain in this patient. This is another patient with a pre-treatment and 12 months post-treatment with a large head and neck plexiform. And you can see the trachea is now opened, the tumor is smaller, and even the stuff that's pressing on the cranium and this was a 31% decrease. And with these large volume tumors, 10% decrease is a lot, 30% is immense, 50% is something we have never seen before. And this is another patient from Dr. Bornholz from our group, and this, you take a look at, this was at 37%. And most of these patients, if you look at quality of life, had symptomatic improvement. And when you plot this, you take a look at what was happening to these patients before they were treated and after they were treated, and you can see over time that many patients had that 20 to 40% decrease in volume. Now, one of the things, unfortunately, that we found with the plexiforms, which we have not yet found with the gliomas, is that if you have to reduce dose or omit dose, these things start to activate again. So some of the patients that Dr. Wiedemann at the MCI have treated have now been on this medication for 7 to 8 years. And the families are very hesitant to come off until they really get them into adolescence or young adulthood. And in general, the remarkable thing is the mechs, as best we can tell, have been pretty well tolerated, even for prolonged use. So the next studies are going to be how useful is this? These were patients who were growing. How useful was this in patients who are symptomatic and not growing? A primary outcome measure is progression, which means all of these studies are really long studies to do. And we have a variety of potential dual therapies. But so far, MEK has been so effective that we are trying to predominantly see what we can do with MEK in combination. A second MEK inhibitor, the Pfizer drug, is in study through what we call the Neurofibromatosis Clinical Trials Consortium. We are looking at that drug. And then here we're doing the same kind of treatment, but we're evaluating it for response, not only really for progression-free. And on most of these studies, we say if you do not see shrinkage by 9 to 12 months, you should come off the study. But one of the things to know about the MEK inhibitors, it can take months to see benefit. And the study is open, and we don't have results quite yet. Another interesting drug, which hits different parts of the pathway, is cabozantinib, which targets as MET, as well as VEGF and KIT. And this drug is in trials and has gone through the phase 1 and phase 2 trial. And actually, this is also a useful drug. It is a little bit harder to manage because of the blood pressure issues, but there are just some patients who don't tolerate the MEK inhibitors well, but tolerate this drug a little bit better. And this came out of data from Wade Clapp, who in a different kind of model showed in an animal model that this drug could shrink plexiform neurofibromas, and that's why this study is underway. Initially, it was only for children greater than 16 years of age. Now it's been dropped down to children between 3 and 16, which we think is the group that may benefit the greatest. We know we have responses in the older patients. That's going to be reported at ISPNO, but we don't know yet its tolerability in the younger patients, and that's the study that is going to move forward. So these are the two drugs. And the one that we just opened, because of the difficulty in getting the AstraZeneca drug to our patients, has been a different MEK inhibitor, the array drug, or bimetinib 162. As we talked about previously, this drug, the bimetinib, is almost exactly chemically like the AstraZeneca sulimetinib drug. It differs by just one molecule. And there is some data that it may be easier to give because this is only a daily treatment where the sulimetinib is twice daily. And we're just taking a look at that drug now. This trial is just opened for plexiform neurofibromas as we try to look and see which of the MEK inhibitors will give us the best benefit with tolerable toxicity. And we talked about the Gleevec or metinib. That drug is not a dead drug because of that response. But once again, with that drug, we don't see the same kind of uniform decrease. Actually, about 70% continue to grow, although maybe a little bit slower on the Gleevec. But there is one study that is just open for airway tumors with that. And it's one thing if you have trouble getting the MEK inhibitor and maybe with cabozantinib is still a little unproven. For the airway tumors, for whatever reason, the Gleevec seems to be a viable option. So that is the story as we move into the plexiforms, which is a dramatic change for us over where we were 5 to 7 years ago. You've got drugs that potentially work. The question is, who do you treat? What is the toxicity? We didn't talk anything about surgery for these tumors, and clearly when you have acute problems, surgery is an option. If you can remove it all, you can often cure the problem, but many for the deep-seated lesions, the paraspinal lesions, all you can do is debulk with surgery, and multiple studies have shown that the tumors will grow back. So even though surgery may have an acute role, and certainly has a role in the older patient when you're worried about malignant transformation, for most plexiforms right now, unless they're really surgically in a completely removable place, we move to the MEK inhibitors as first-line treatment. For low-grade gliomas with NF, we talked a little bit about this yesterday, but one of the big issues is that low-grade gliomas tend to be often an MRI diagnosis. And one of the questions we raise with treating the low-grade gliomas with NF, are we treating the cancer or a chronic condition or both? What are the long and short-term consequences of treating or not treating? And this is the big one for me. Are we treating the child or are we treating the MRI? And if I see an error, it's more of an over-treatment of many of these patients. This is what these tumors tend to look like. Besides bilateral optic nerve involvement, they tend to be these diffuse lesions that go along the visual pathway, and deciding where is tumor, where is dysplasia, where is pre-tumorous tissue can be very difficult. But they are not only in there, they can go up to the third ventricle, they can go down to the posterior fossa, they can do anything they want to do. One of the major things to remember with NF is that these children develop early in life, in about 90% plus, these whitish areas within the brain. And they tend to be more apparent when a child is 5 than when a child is 2. They tend to almost look like they progress, and we just think this is this plastic tissue that just stands out more over time. But if you really watch these carefully, they will go away over time, the majority of them, or a lot of them. So you got to be really careful. They've gone by different names. The name we like is focal area of signal abnormality or intensity, the FASIs. I do not like the term that people use, UBO, unidentified bright object. It's sort of a silly, little derogatory term, and it shows our ignorance when we use UBOs. But, these are, when they've been biopsied accidentally, when people thought they were biopsying tumors, they tend to be somewhat dysplastic tissue, and they tend to go away over time. The other thing that's humbling about NF is it has a very erratic natural history. This is a child I saw at about 4 years of age with this tumor having decreased vision, and even though I don't like treating on the first image, we recommended to this family to go ahead and get treatment with carboplatin and vincristine. The family who lived a few hours from us said, "Thank you very much. We'll see you in a year." They came back and the tumor went back to that. No treatment. 1 year later, they came back once again and the tumor was here. Still, same symptoms. We said, once again, now you really have to treat him because he activated again. And they said, "Thank you very much. We'll see you in a year." And it came down to this. And this child has never received treatment. We have a second patient that had a very small lesion and over a brief period of time developed significant visual loss. So it's really more of an art form and a hunch when you have to treat these children. Our standard is we usually would either want to, if there's really visual loss, which can be difficult to determine in a very young family, we will not sit on these patients. Visual field is extremely difficult to be sure of in young children, and our neuro-ophthalmologist won't make the call, but sometimes we will, because we really have to get in and try to treat the child. At the same time, if there is no visual loss or new onset visual symptoms, and something that helps me a lot is when they develop acute shimmering nystagmus. To me, that's a concern that something's about to go wrong, that we will not wait for at least one other MRI to show that it grows before we would treat. And sometimes we wait for 2 MRIs in a row. One thing we think will help us dramatically in the future will be some of these non-invasive techniques. We have not been able to use visual evoked responses reproducibly to tell us who's going to get into trouble and who isn't. We've used more the OCT with Dr. Rob Avery, who was with us in Washington, is now in Philadelphia, and Dr. Stasheff. And they've done some really nice work I showed you yesterday, that you can, with the OCT, you look at the retinal fiber layer and you can see thinning. And one of the other things you could do is you could see thinning in certain quadrants. And that can even give you a window of opportunity that maybe you're getting into a field cut kind of problems. And we believe there is a threshold for these where you really get into trouble, and we have not yet incorporated that as a criteria to start treatment, but I can tell you in equivocal cases, it does push us to move forward. Now, one of the issues that has been raised multiple times is what is the risk of irradiation for these kind of NF lesions? And we are concerned very much about malignant transformation, secondary tumors, leukemia, vasculopathy. The risk, however, if you really look hard, is not well documented. It's small case reports. And the alternative treatments, especially if you're going to be willing to go into alkylators, which we try to stay away from, like temozolomide, is really a big issue. It's not an absolute contraindication. We have occasionally used it in brainstem lesions, and I'll show you why there may be some that you may have to use it more. But in general, we do try to stay away from radiation as much as humanly possible. And the backbone treatment that we've used for years, that was reported by your group earlier, I think Angie reported this, was the use of carboplatin and vincristine. And independent of how well you think it works or doesn't work versus vinblastine in the non-NF kids, and it does work well with the non-NF kids, it works dramatically well in the NF kids. And if you take a look at a series of patients through the Children's Oncology Group, 127, with theoretically progressive plexiforms, and this is, you've got to know who made the decision it was progressive. You take a look 7 years out, 75% of children who started treatment have remained in continuous remission. And many of these have shrunk. So not for everybody, but if you have treating NF-related low-grade gliomas, 75% will benefit from the chemotherapy alone. Now, clearly we would like to stay away if we could from chemotherapy for a variety of different reasons, and there have been other trials. One of the earlier ones was the use of mTOR again, and there's a study that has been done in NF1 using RAD01, which is the mTOR inhibitor. And this study Mark Kieran led it for the children's brain tumor, the Neurofibromatosis Clinical Trials Consortium. And then he led that, and it's completed. And all I can tell you again is that there are responses, but we haven't completely done the data. But if you take a look, there's about a 20% to 15% response rate in a lot of stable diseases with the mTOR inhibitor. And we've tried to use the mTOR inhibitor, as we said yesterday, in combination with EGFR, but we did not see, with using Tarceva, any real additional benefit. Again, a lot of stable diseases, some occasional home runs as a single agent, and one of the questions is whether this will be a drug in the future to combine with the MEK inhibitors. And this is one of the best responses to the mTOR inhibitor. We've had experience before we started using the MEK with bevacizumab and irinotecan. Dr. Wong helped us compile this data, and we talked about this yesterday. This was not an NF patient, but you can see some really dramatic responses. But the thing that was most impressive in kids with or without NF was that we could see recovery of visual field and neurologic function where we didn't think it was possible to recover because the length that the child had the deficits. We don't fully understand it, but it's a legitimate approach if you fail carboplatin vincristine. One of the things that becomes a very interesting question is that if you have an acutely deteriorating patient and you have to start chemotherapy, and you know that chemotherapy is going to take a while to work, is there benefit of adding the bevacizumab or Avastin on top of the chemotherapy for 2 to 4 months to buy your time for the chemotherapy to be of benefit? Because we know that the visual acuity outcomes after chemotherapy have been variable. Some kids seem to lose acuity, most stabilize, and not many improve. So we have gone to the point off treatment that we are willing to consider using bevacizumab with carbovincristine in acute situations of rapidly falling visual loss as new therapy. And this was a study that was done for low-grade gliomas, and again, the Avastin with the irinotecan or without has a pretty good response rate. And Dr. Wong, as we talked about yesterday, is the U.S. lead for the bevacizumab trials in the United States, comparing it to a randomized trial with or without vinblastine. We think this is a really good approach in some of the older kids with NF, but the reality of life is most of the kids with NF that get into the visual problems get into it the first 3 to 5 years of life. And then after about 5 years, the tumors stop growing. 5 to 6 years in about 90%. The question is, are you going to randomize to this trial, or would you use carboplatin vincristine alone? Or if you have rapid vision drop, do you add the bevacizumab? Those are things that are being worked out, and hopefully as we get these trial results, which looking at progression-free survival at 12 months, we will have a better idea in the NF children, the relative benefit of this approach versus the carboplatin vincristine. And we talked about this yesterday. This is open for children as young as 6 months of age, both with and without NF. NF does not require tissue, but it's also following visual improvement, which I think is very important. The next thing that really did break open for the low-grade gliomas and NF, as you well know, are the MEC trials. And one of the things we're going to talk about at the end of the MEC trials is that NF1 is rarely associated with any other kind of loss. But in some of the older patients with gliomas, we are seeing some concomitant NF1 and BRAF mutation, NF1 with concomitant FGFR mutation, and the one that's worrying us a great deal is NF1 with CDK and 2A loss. And that opens the possibility, although we recommend treatment without biopsy for NF1, because we know these patients likely have a pilocytic astrocytoma, we have to be cognizant that in the future, especially if patients break through therapy, we may require biopsy to see if there's a concomitant additional mutation. And once again, we're really looking at RAS MAP kinase pathway. And this was one of the earlier patients with not with an NF lesion, but with a low-grade glioma, so a sequential, beautiful response to the MEK inhibitor. This is a child with NF1 showing response and clinical improvement, both on the enhanced scan and on the FLAIR image. So the primary focus tends to be MEK inhibition for the low-grade gliomas. We know that there are multiple different MEK either in clinical trial or just completing clinical trial. Our greatest experience has been with the sulimetinib. There's increasing experience with the bimimetinib. We have not used cobimetinib, and the Pfizer drug, which we have talked about using, and its major risk tends to be retinal damage. And this is what's held back the MEK inhibitors. The MEK inhibitors have caused skin problems, but they also, in initial treatments, cause central venous obstruction and visual loss. Those were at different doses and predominantly with some of the earlier drug, the Pfizer drug, but this risk has really held back the field until recently, appropriately. Now we do sequential OCTs, we look at the retina carefully, and in general we've been able to not see major problems. You at times see some separation of the retinal layer fiber on some of these MEK inhibitors. We've held drug, other people treat through that. It may not have anything to do with the central venous obstruction. So the issues with the AstraZeneca drug has been, where could we get the drug for many years, and should we combine it or should we use it as a single agent? And there was, for many of our young kids, this was a big problem, no liquid preparation. But there's no question that the AstraZeneca sulimetinib drug is really very active, as you can see in this case of a child with NF and a very diffuse, unusual tumor. And if you look at children without NF1, I showed this yesterday, about 70% have some decrease, but this is the dramatic thing with NF1. In the younger, and these are predominantly children with chiasmatic, but some with brainstem gliomas, you can see that with NF1, there's almost a uniform reduction in tumor size with the MEK inhibitor, sulimetinib. And the question that really has been raised is durability of response. Most of these children were treated with 2 years, but some were treated with 1 year of sulimetinib. If we take a look at the children who were off of treatment between July of 2014 and May of 2017, only 6 of 24 had to be retreated, suggesting that at least in the NF patients, there is quite a bit of durability of response. That wasn't quite as well seen in the children without NF, where over half of the kids, and now even more, have needed to go back on treatment. So our focus of what we're trying to do with this drug is really not to say, does the MEK inhibitor work? It shrinks MRI. It shrinks tumors on MRI. But what is its assessment on functional outcome? What does it do for vision, neurologic function? And what we wanted to do is really a single-arm study with AstraZeneca, looking very much at quality of life and vision. But the decision by AstraZeneca was to go to a randomized trial to prove that it's as equal to or better than chemotherapy, randomizing it against standard carboplatin and vincristine. This trial is about to open the next 2 or 3 months. It will evaluate vision. It will look at quality of life. But the primary outcome measure for this trial is going to be progression-free survival. And I showed you with the NF patients how well they've done with chemotherapy alone. So it's going to be really hard to prove that this is better. And if it doesn't show that it causes less side effects and a better quality of life, we have a real risk that we can potentially kill this drug. This will be the study that has been moving forward, and to make this work, 2-year progression-free survival on the MEK will have to be between 77 and 88%. That's a very high bar for any drug trial. But we're going to go forward with it, and we're going to hope we get more of acuity and function endpoints. Trametinib is another drug, but has not been used as widely in NF1. We have used it when we haven't been able to get the AstraZeneca drug. There are responses both for plexiforms and for optic gliomas, and we don't know the relative value. And as we said, the drug that we're very excited about is the Array drug, because it's very much like the AstraZeneca drug. And this is now open a low-grade glioma arm with Dr. Robinson at CHLA through the Neurofibromatosis Clinical Trials Consortium and the Pediatric Neurooncology Consortium running this trial. And we really think that this drug will potentially have a role to play, and it is running, and has a very major focus on NF2. And it's going to be looking very hard on patients with neurofibromatosis. The Pfizer drug, I'm not going to spend much time on. I don't believe that drug is going to go forward because of some toxicity and availabilities. So what is the most effective? We don't know. They clearly have some similarity in efficacy. They're different molecular structures. They really have to be measured about functional outcome. One of the big issues is how important is blood-brain barrier. If you take a look at the sulometinib drug, it shouldn't work. It doesn't get into brain very well, but clearly it's extremely effective. So there's we don't understand that as well as we should. And one of the big issues with all of these drugs, whether plexiform or whether it's for low-grade gliomas or over time for its cognitive issues, will the toxicity be worth it? And which actual drug will survive? And this again are the drugs, the variety of different drugs, and it's going to be a matter of time. And I think that right now the AstraZeneca drug, the main issue is that it was only in tablet form. Sprinkles will be introduced. The Novartis just has not had a lot of NF testing with it. The Pfizer, I think, is not going to go ahead. The Array drug we're looking at very carefully, and I just don't know enough about the cobimetinib, the Genentech drug, to give you any data. And so, other question we're going to have to ask is, are there escape mechanisms for NF? Are you going to need to combine this with other therapies? We don't know. We think for low-grade gliomas that are non-NF, you're going to have to do that. But for NF, it's not as clear. Use of chemotherapy was approved in 2014, but the company blocked it because they were worried about additive toxicities. We tried to get it used with mTOR. Dr. Gilbert in our group had a study approved, and it was blocked by our national organizations because they were worried about overlapping toxicities. It is going to be first tried in combination for malignant peripheral nerve sheath tumors. Some nice data out of laboratories, including laboratories at Children's National showing that RAS MAP kinase signaling is a major issue with malignant peripheral nerve sheath tumors. Yuan Zhu has shown that, and Dr. Kim is going to be running a study. And if we see tolerability with this combination, we will probably move it into the low-grade tumors. There have been a variety of different consensus conferences about NF, and I showed this before because what we did in the consensus conference was that we did not suggest biopsy for any child with NF1. The newer data coming back, talking that some children with NF1 low-grade gliomas, the tumors are not only of NF1 but have concomitant other mutations, especially CDKN2A, in older patients, leads to the issue of whether we should be considering biopsying NF1s when they are smaller, when they are atypical in a non-standard setting for NF1. Meaning that if you have an 18-year-old that has failed therapy, or a child who had a low-grade glioma for many years who was stable and then activated, maybe those are the children, and now young adults, who need to be biopsied to pick up some of these concomitant other mutations, not only BRAF, but CDKN2A and other mutations that probably suggest why older patients with NF1 and gliomas often have a more aggressive course. The other things that are coming down the line for NF1, we've been very interested working with a group at Arizona State University asking, do NF1 patients have a specific immunosignature that we could use both for diagnosis and for possible vaccine development? And this is a very unique type of approach, and we won't go into details, although the interesting thing is in our preliminary data, this is how medulloblastoma is subgrouped by immunosignature. And you can see that there's a different immune signature depending on the subtype of medulloblastoma. We have similar data that I really is still very preliminary, that NF1s with plexiform neurofibromas have a different blood immunosignature than the immunosignature of those with low-grade gliomas, or those with not either low-grade gliomas or plexiform neurofibromas. And there's going to be some additional trials trying to see if we can continue to do this. Last couple of things with NF1 is we talked about the gliomas, the plexiform neurofibromas. We didn't talk about the malignant peripheral nerve sheath tumors. We'll talk about that in a second. But if you talk to families with young children, the overwhelming, most common problem these patients have are the cognitive issues. And one of the interesting questions is, can you use different therapies to improve cognition in patients with NF1? And there have been mouse models developed by a variety of different laboratories that seem to recapitulate some of the problems children with NF1 have, the attentional problems, the visual spatial problems, the poor planning, even though with IQ in the average to low average range. But clearly this mouse model, although perfect, and the mouse model is not perfect because it doesn't recapitulate everything the child does, but it has been a way to potentially test drugs. And this was the rationale for the use of lovastatin in patients with NF1. Interestingly, the MEK inhibitors worked very well in this model to reverse some of the learning deficits, but they were thought to be too toxic to be used. And the lovastatin, based on the Silva model that was developed at UCLA, we did a large study through the Neurofibromatosis Clinical Trials Consortium, looking at these different functions in children between 8 and 16 with the drug. And unfortunately, these aims were not met. The lovastatin did not make a difference, even though there was 5 years of work trying to evaluate these patients. Methylphenidate does have some benefit. Montner showed that in 20 children in an open-label study, at least for the attention problems. You sometimes have to use higher doses. And the work of Dr. Hardy at Children's National, that's now a national study for cognitive training, has really opened a new window of potential benefit for these patients. Her work in leukemia patients showed that it had some longer-term benefits, not just during the cognitive training. And there's a trial right now that we're doing randomizing between patients getting stimulants or stimulants with CogMed. And this trial is going to be an interesting one. And right now, there's just not enough comfort with the MEK inhibitors to utilize them to try to improve cognition with NF1. Saying that, all the patients with NF1 that go on studies at our institution and at the National Cancer Institute for plexiforms or for low-grade gliomas get baseline neurocognitive testing and sequential testing down the line, and in preliminary results, we've seen no decay in intellectual functioning and maybe some tantalizing improvement, as you've seen in the tuberous sclerosis patients who received rapamycin. Bottom line with NF1 is it's really changed dramatically. It is a clinical trial condition right now. It's one where we have a host of new potential interventions, maybe some that are going to have to be tweaked because of toxicity. Others, to be honest, that maybe we got lulled into this as a single pathway disease, and for the older patients who develop low-grade gliomas that progress, they may have picked up other mutations. But we think that the major change has been the use of MEK inhibitors to try to treat these. Which is the best MEK inhibitor? What's the safety profile? Who needs to be treated is really an important issue, very important issues. But at least we have some therapeutics finally for this very needy group of patients. Thank you very much for your attention.